All right, well, it's 12:02. It looks like people are getting logged in. So we're going to go ahead and kind of get things going today. Again, thanks everybody for coming to the quarterly APDR Roundtable. The topic today is speed, kind of the elephant in the training room. How do we assess our resident speed? How do we teach speed? And how do we help residents struggling with it? We won't be able to kind of fully answer every single thing about this today, but we're hoping to open this conversation amongst program directors and educators of radiology residents, fellows, to kind of start moving forward and maybe establish some best practices to help our residents. Our moderators today are me, Carol Geer. I'm the Diagnostic Radiology Residency Program Director at Wake Forest. My colleague, Scott Wuertzer, who's the Associate Program Director of the Diagnostic Radiology Residency at Wake Forest. Eric England will be presenting with us today. He is the Vice Chair of Education and the Diagnostic Radiology Residency Program Director at the University of Cincinnati College of Medicine. And we also have David Hodges here to present and give us the private practice perspective on speed. David has been in private practice since 2009. He has a fellowship training in musculoskeletal radiology and has worked his whole career with ARA health specialists and is based out of Asheville, North Carolina. I also want to give a special thanks to one of our R4 residents at Wake Forest, Kyler Harden, who did a huge deep dive on the what's out there in the literature on teaching and assessing speed and radiology. And to make a long story short, after Kyler spent a long time kind of going through this, there isn't that much. And so I think it's a topic that's kind of ripe for us to kind of work together on. And again, I have nothing to disclose. So without further ado, speed, how much should we focus on it in education? And I want to just put it out there. Accuracy and knowledge is critical. Okay, that's most important in radiology. And quite frankly, I think as educators, we do a really good job of this. There's multiple ACGME milestones out there that are really focused on assessing accuracy, proficiency, and knowledge in radiology. Of course, we formally evaluate all of our residents on these milestones every 6 months. Our CCCs get together and we assess residents on accuracy, proficiency, and knowledge. We have multiple objective exams that we give our residents yearly that formally assess knowledge, including ABR core exam, RAD exams, ACR in-service exams. We do readouts, with our residents during the day. And in those readout exchanges, we can, assess their knowledge bases and their accuracy. We also overread our resident reports on call, and, residents take call and we can assess accuracy and knowledge in those settings. And there's lots of really great presentations that are given every year at national meetings. They're really focused on teaching accuracy and proficiency. So where is speed in the ACGME milestones? Is it there? Well, it turns out it actually is there under the professionalism competency in the accountability and conscientiousness milestone. Level 2 is performs tasks and responsibilities in a timely manner. And I would say timely manner is equal to speed in my mind. To ensure that the needs of patients, teams, and systems are met in routine situations. Level 3 is timely manner in complex or stressful situations. It's also speed kind of shows up under the patient care competency under the reporting milestone. Level 2 is that you efficiently generate clear and concise reports, which do not require substantive correction. I take efficiently maybe to equilibrate to speed. Level 3 is efficiently generates reports that rarely require correction. And level 4 is efficiently create reports that do not require correction. So speed's in there, at least in some manner. So how much should we as program directors be focusing on this for our residents? Is it something that you are focusing on? Is it okay for our residents when they finish to be really, really accurate, but very slow? Is that okay? And I would argue it's probably not okay in today's world. I don't have to tell anyone on this webinar that volumes in radiology are increasing, the complexity is increasing, and it's massively increased just in 5 years. And unfortunately, I hate that we even have to talk about speed, but I think it is something that we need to, in part, be focusing on and helping our residents get to a certain point in speed, because I think for practicing radiologists, if you lack pace or speed, that can lead to difficulties with you being successful in a practice. It can lead to, there's lots of things out there about attendings or people in radiologists in private practice needing to change jobs because of difficulties achieving speed, feelings of inadequacy, even depression, feeling bad about forcing colleagues to handle more of the volume because you don't have speed. So if we think speed is important, how do we as program directors, one, assess this competency, speed, and how do we help our residents get better at it? And this is where Dr. Scott Wuertzer is going to talk about some experiences in a training program with a framework of an independent call system, meaning a call system that does not have faculty reading cases alongside residents overnight. Dr. Eric England's going to talk about assessing and teaching speed in a program that does have 24/7 attending coverage on call. And I want to be very clear, our webinar is not, we are not here to discuss merits of independent call versus 24/7 attending coverage on call. None of us as program directors have any control over this. And so we have to teach in the systems we have, but speed can be taught in both systems. And we're going to talk about that. That's where Scott and Eric are going to give their perspectives and start opening this conversation. And finally, do hiring practices care about speed of our trainees? Is that something they care about? Well, guess what? We all know they care a lot about it. One of the first questions that we all get when hiring practices call for references of our trainees, they always ask us, are they fast? How fast are they? And we have to ask ourselves, do we know if a trainee has good speed? Do we know how fast they are? Do we know if they can handle the pace of a practice where we're providing a reference for? And this is where David's going to come and talk about the private practice perspective and expectations for new hires. So with that, I'm going to stop, and I'm going to stop sharing my screen. I'm going to hand it over to Scott Wuertzer to talk about a program's experience with speed, and then he'll hand it to Eric and Eric to David. And while Scott's pulling up, we will be manning the chat room. So chat in, and their questions and answers can also be done as well.
Okay, so thanks, Carol. Hopefully everyone can hear me. Good afternoon or good morning, depending on where you are. As Carol mentioned, I'm the Associate Program Director. Carol and I have worked together for the last 10 years or so, and it's given us an opportunity to talk about speed, and I'm excited to do that today. Thanks also to the APDR for this opportunity. Just a quick outline. I'm going to give an introduction, some thoughts, then we'll get into ways that I think you can assess speed, teach speed, and hopefully increase speed. And as Carol said, I'm going to do that through the lens of an independent call system. We found this to be a valuable tool in terms of assessing, teaching, and increasing speed. And then I'll give a few kind of remarks to conclude. So in terms of an introduction, I don't think that we have our heads in the sand when it comes to speed. I mean, if you're attending this roundtable, then you're clued in. If you're an attending radiologist, you know about speed. I do think there's a potential, though, to have our heads in the sand when we're talking about speed with residents. Speed, it can kind of be this sort of nebulous black box kind of floating in the background as we move through residency. And so that's one of the things that we're going to try to hit on today, is kind of bringing up the topic of speed, if nothing else. Carol's already mentioned this a little bit. It's kind of hard to get away from this to some degree, this balance between speed and accuracy. If speed goes up, does accuracy have to go down? Again, this is a very kind of hot topic, or a kind of a hot button topic. You can talk a lot about this, but I am going to try to just focus on speed. I found an article from AJR 2019, and you can read that as well as me. But basically, it's saying that you can have accuracy and probably not have speed be a factor on that. And so again, I think as radiologists, and particularly in academics, it's hard to let this piece go, but we are going to talk more about speed today. I'll work accuracy back in at the end. I think you can have both is kind of the key, but you have to think a little bit about speed. So how can we assess speed? When should you assess speed? So the early bird getting the worm here. I think you can start early in residency. Again, first years, just bring up the discussion at some point. Helps the resident kind of develop a self-awareness if they realize that they're lacking in speed a little bit. And a lot of the residents are very clued into this. I mean, they're going to set up a meeting with Carol, for example, and talk about it, or they're going to start building their speed as they move through residency. And they're going to be able to do that in an environment where they can practice that. You can develop speed on your daily rotations or call, which I'll talk about at the end with call. But daily rotations, I think it can be as simple as sort of setting expectations. So I'm an MSK radiologist, and this is a screenshot from our handbook that I give to our first years when they come through their first MSK rotation. And you can clearly see that I've laid out, what's the expectation in terms of a number. Now, is 50 too many for them to get through on July 1st? Yeah, absolutely. But we know by the time they get into the fall, and particularly this time of year, they can easily read 50 plain films. And so I realize that not every rotation can be set up like MSK, but you can certainly set expectations. You can do that in terms of volume and numbers, and in a way start working towards some speed. How do you assess it? Well, a lot of times, again, as I've already said, the residents are very clued into it. I mean, they know how many studies they're reading. They know if they're meeting these expectations. A lot of times on our rotations at Wake, we'll have first years, for example, paired up with other first years. So they're sitting up side by side, again, which allows them to sort of bounce ideas off of each other. They know, again, how much volume their colleague sitting beside them is reading. Sometimes we'll have residents as they get ready for call. We'll have them do a call practice. We have some software that they can go through, and sometimes they'll time each other or time themselves. And so again, yet another way that they can sort of assess themselves. As faculty, how can we assess their speed? Well, again, same sort of thing. I mean, you're going to have access to those numbers. So if you feel like you need to bring it up during a semi-annual, you can. I think there are certainly tactful ways to do this. It's not going to be the first thing that you bring up during a meeting, but it is nice to have some of that objective data that you can compare across a class, and you can see if somebody is an outlier. For us, as we said, performance on call can help trigger certain factors. If there's someone that needs backup frequently, I mean, if it happens one night or two nights, that's not a big deal. But if it happens 7 nights in a row, then that's maybe a tip off that you need to practice some speed or think about speed a little bit. Of course, your CCC can play a big part in this. Aside from the milestones, which we talk about every CCC meeting, you can also get into kind of accuracy, speed. And this is a question that we ask every resident as they sort of progress through. Are they ready for this next level of call? And sort of embedded in that question is the idea, are they fast enough? Can they do it? Okay, so assess speed. And then the next thing is trying to teach speed. I think, again, you do this early in residency. You kind of lay out your tools there. Again, I think we all do some of this. I'm sure we all do some of this in our residency, particularly with first years, just being sure that they've got templates that are ready, just being sure that they know kind of appropriate hanging protocols, that they have all of the kind of technology tools ready to go. Search patterns, we all know about this. This is that same screenshot. And this is one thing that I do. I think it's a little bit different for MSK. We'll have them look at certain joints on certain days. And so what I'll do is I'll have shoulder day for them, for example, and they'll watch a video the night before that's on the shoulder. And then the next day when they get to work, they can just itemize it or pull it up by column and look through and go through 20, 30, 40, 50 shoulders in a row. Residents like this, it allows them to kind of build these search patterns and get faster and faster. Pre-call. We spend a good bit of time with what we call a call preparation series. These have been very well received. We do these in the fall in preparation for call starting at the beginning of the year. Again, we've got neuro series, body, MSK, And the residents are just laser focused during these sessions, again, because they're conscientious, they're a little bit anxious about starting call, and they're very focused. And because they're so focused, the attendings love giving these series. So it's been really a good mix for us. We also have them do a buddy call where they're paired up. So the resident that's starting call will be paired up with an upper level. And the idea here is just that they're ready to go, that they've got all the tools that they need. They know where to sit. They know what phone to answer. They know what cues to put things in. And so there's no kind of problems when they do start call. Later in residency, can you continue to teach speed? When and what does that look like? I think you can continue to kind of increase your expectations as people move through the system. Again, you can change those numbers that we talked about on the syllabus, for example. Another thing that we do at Wake that has helped kind of increase speed as you move through is have some sort of system in place, whether it's a call system or a simulation system, but something that continues to challenge them as they get into the fourth year in particular, where you spend all this time in the first 3 years getting them ready to go, and you get to fourth year and they maybe kind of plateau a little bit, but I think you can continue to teach speed. Okay, so let's say that you are able to assess speed, that you can teach speed and do some of these tricks, and you still have a resident that it's not quite clicking with. How can you increase speed? This is a hard one. I think, again, you may start thinking about sacrificing accuracy a little bit, but I think it's important to build confidence in the resident, and you can do that by some of the things that we've already talked about. Are you setting expectations that they can meet on the daily rotations? On call, if it's too hard for them, they're going to lose confidence. If it's too easy for them, again, that may be a problem as well. You can set up teaching so that it sort of optimizes what they get on call. If they're reading a study on call that they've never heard any didactic or had any teaching on it, then that's going to be a problem. That's going to slow them down. Sometimes you need to have a resident kind of repeat a rotation. And I think that we know that you can kind of tactfully do this and get them back in to get more reps in a certain area, allowing them to build confidence and ultimately speed. Program directors, this is where this is a tough conversation, or can be. The fish bowls, they're the same size for different size fish. Not every system or not one size fits all. I mean, again, you're going to have these discussions occasionally, talking through, you can handle this pace or you can't handle this pace. Not everybody can handle a certain pace. And these are conversations that I think we probably should be having more often than we do, talking about getting somebody ready to get out there and practice. Are they ready? Can they do this job? And can they handle it in terms of speed? Feedback, same sort of thing. One of the things that I do with residents as they come through the MSK rotation is what I call Feedback Friday. I kind of like the alliteration there, but I meet with them every other Friday or so. And the idea here is it's kind of a two-way street. I get to hear their thoughts on the rotation, and I get to give them feedback. Does speed always come up in this discussion? No, not necessarily. But if they want to talk about it, yeah, sure, we'll bring it up. Or if I feel like they're kind of off the curve a little bit, then we can talk about it. We've already talked about CCC. That can be very valuable feedback in terms of speed and getting someone a little bit faster. And then call. So call is kind of what we use is probably our best tool to increase speed. And I'll get into that. As Carol mentioned, the idea here is not so much to force the idea of independent call. It's just the system that we have at Wake. It's the system that's worked for us. It's allowed us to do some of these things: assess, teach, increase. Assessment of speed is pretty straightforward. You're going to have the data. You're going to have these numbers. You're going to know how many studies they're reading, what types of studies there are, if there's trends across call shifts. As we mentioned, how frequently does a backup person need to come in? Change the reports, that's going to go more towards kind of accuracy, obviously, but all this data is going to be there with an independent call system. And then the expectations of a call system are pretty straightforward as well. Again, it kind of sets itself up for you. You're going to have the emergent studies to read, and you're going to have an expected turnaround time. And so again, if you're doing this, if you're meeting these expectations, hopefully there's going to be speed that comes out of that. It's just sort of embedded within a system. Now, this first bullet here is kind of another sort of controversial thing. How much do you push the resident? Finding that sweet spot of what they can do versus pushing them too much. Again, that can be a whole other conversation, but I think you can help kind of push them a little bit with speed. You can certainly highlight areas that need improvement, whether it be speed or accuracy with an independent call system. And as they move through these different systems, so we have kind of a tiered system, which I'll talk about the last couple minutes, but that allows them to build confidence. They move through one tier system, they feel good about it, they move to the next, and then they move to the next. I think there's one final thing here I wanted to hit on in terms of a call system, and that's some of these things I'm calling intangibles. It kind of is on the periphery of speed. I mean, you've got to learn how to handle distractions, phone ringing, technologists coming in, working through your list, triaging if multiple studies come in at once, what's the study that you need to look at. I think some leadership skills can come out of a call system potentially if you're an upper level working with a lower level, kind of managing that list, sort of giving guidance to the lower level, and hopefully developing some leadership skills from it. So as you move through your system, how can you continue to increase speed with a call system? Again, I've already mentioned this idea of potentially having some sort of system for fourth years. It gives them a chance to apply new knowledge. Hopefully at this point, they passed the core and they're ready to get out there and sort of show off, so to speak. So you'd like to see all of these things moving upward: speed, intangibles, accuracy. You can vary your call to get to this point, as I mentioned. We have a tiered system that starts early on, tier 1, tier 2, tier 3. And then our final call is a short call, which the residents love. It involves all types of studies. It goes from 5 p.m. to 11 p.m. The residents, the fourth years, manage this together, and it gives them the chance to work together. It's a high volume, but it's all different types of studies, and they feel very confident when they finish this call. And again, I think it allows them to sort of get ready to moonlight if they want to do that, and it gets them set up for future practice. So that's how I think that an independent system can help with speed. Just a few things to sort of wrap things up. My final thoughts: I think you start early. I think you kind of plant the seeds, at least talk about speed. I think that you can then kind of go on and build some confidence, water the plant, so to speak. And then you get to the end where you've got them in some system. And again, as we said a couple of times, it doesn't have to be an independent call system, but I do think it's nice that you've got some system that's challenging them, that's pushing them a little bit, that's making them think about speed, that's making them develop that confidence, and again, get ready for their future job. And that's going to be it for me. Thanks, everyone. Thanks again to the APDR. I'm going to stop sharing and let Eric have the stage here.
Great. Thank you, Scott. I appreciate that. And thank you, Carol. This discussion is very near and dear to my heart, which I'll go into a little bit. And I'm glad to be able to kind of share my story, because I think it's particularly important to take into account specific circumstances and situations in each of our residency programs. And in my case, the one that I'm kind of describing is really speed in the age of 24/7 attending coverage. So to give you a little background kind of about myself, I started as program director here almost 10 years ago. And this was right on the cusp of when our department was going to 24/7 attending coverage. So as you can imagine, this was the first major challenge I faced. I'm sure all of you, when you first came into position, had, a major challenge and you're like, what am I going to do? And it took a lot of work for a lot of people to figure out how we were going to face this, because it was really just early on in this kind of 24/7 attending coverage. And, I remember having multiple discussions with faculty and residents, and, faculty feeling like this was on par with the apocalypse, right? The only way residents are going to learn speed is if we throw them to the fire and they either sink or swim. And our residents that are going to come out of the program are going to be severely affected. They're not going to be on par with other residency programs who might still have kind of this independent call. And, to be quite honest, I myself, who was trained in a very, independent call, resident run program, had some serious concerns as well. And it really took a lot of discussion and coordination with the faculty and residents to have a plan on how we are going to address this situation. We put it to the forefront, and we made it a priority. And this is only becoming more and more of a priority. I mean, back 10 years ago when I started, I think during my research, it was about a quarter of programs had this 24/7 attending coverage. And now it's probably up to half or a little over half based on the most recent research. So this is very important to kind of all our programs. But we still want to address speed, and we still want to cultivate that development among our residents. So going over a few things and kind of breaking them up into sections based on kind of how we approached it. And the first thing that we needed in order to address this was really buy-in. buy-in from faculty, buy-in from residents, that this was an important part of their training. Faculty needed to be invested, as this was an important part of the educational mission, and residents had to be self-aware that being an efficient, accurate reader was one of the most essential skills they develop for when they go out either into private practice or any other type of job after residency. And actually, for the most part, this was easy. I think most of us went into academia because we care about residents, because we want to have we want to impart them our wisdom and make them the best radiologists that they can be. They're really our future. So convincing the faculty to prioritize this really wasn't as hard of a job to do. But the key to this is you really had to get buy-in, not just from the faculty, but from leadership as well, but from committee leadership specifically. So it was going to take more effort and time. Everyone just can't say, yes, it's important. It's going to take work, right? And having specific buy-in to that work was really going to be important, specifically at the resident evaluation level. So what I'm talking about are CCC committees, program evaluation committees, or educational committees. This needs to be evaluated on resident self-evaluations. I found that residents are sometimes even harder on themselves than they really need to be with regard to evaluating speed. So when we have our semi-annual evaluations, residents evaluate how they think they are doing regarding speed evaluate themselves. And this is a very important part of the process. And finally, peer-to-peer evaluations can also be important if you have that as a part of your self-evaluation. So one of the challenges that we did face, other than kind of prioritizing this with the faculty, was especially, within maybe the past 4 or 5 years, and I'm sure this is happening at most of your institution, is the incentive or almost the mandate to some extent of faculty needing to be more clinically productive, right? This has been discussed, at AR meetings before, and really balancing that clinical, educational, and research mission. Well, we're getting more and more pressure for faculty to produce clinically, and honestly, one of the easiest ways, and what I would consider a shortcut, is to, read more on your own, right? When you're reading a study on your own, you don't necessarily have to teach, you don't have to edit reports, and you don't have to teach about the studies that you're doing. And that was really, I think, a culture that, we saw early on and wanted to address and reestablish the importance of having faculty prioritize residents picking up cases and developing speed, right? Because if faculty want to decrease their turnaround time and increase output, it was leaving fewer and fewer cases for residents to feel like they needed to read in order to develop the needed speed. So that was an important aspect that kind of occurred more recently. And although I'll focus on more of kind of the ED overnight call staff as playing a large role in overseeing the development of resident speed, I don't want to leave out the daytime staff as well, because really, and Scott talked about this a little bit, it really needs to be emphasized on every rotation, even from nukes to breast to MSK. This needs to be, globally discussed and prioritized across the department. But I will say, having our ED and on-call sections take the lead in evaluating how residents are progressing with regards to speed is essential for feedback to our CCC committees. So the second thing I want to discuss, the first was the buy-in, and the second is really having a good way to monitor progress. And this becomes more important because there's not if you're on an independent call and you have all these studies left over and the ED is calling and complaining, then you're going to know that resident maybe isn't as fast as they should be. But in an age where there's 24/7 attending coverage and attendees can pick up the slack, you really don't see that. So how do we monitor this progress? Well, the good news is it's not subjective data, right? This is objective data that's available. And actually, in my opinion, subjective analysis can be hard and prone to biases and interpretation, but objective data isn't. It is what it is, right? You read this many chest x-rays during an 8-hour shift on average for this month, or, whatever metric you want to set. And I think this is very powerful information for the resident to have and for the faculty to be evaluating residents. Call volumes. If you have a 1 week stretch of call, not every day of the week is going to be the same. Sometimes maybe you're going to be pushed to do an emergent floral procedure, and that may decrease the total number of other studies you read. But having on average, how many cross-sectional studies this person did during their shift, and is that, what we expect it to be, I think is important. At our institution, we have 2 residents on at any one time, and actually without even me asking, they'll monitor each other's progress and speed to make sure that one person isn't taking the bulk of the work and the other person. If one person's slower, they're more self-aware. Okay, I really need to pick up my pace. No one wants to be kind of seen as maybe the slower of the two or the weaker link of the two. And we found this kind of social comparison very, very important in developing speed. So I don't even actually have to encourage this. And I'm finding actually more and more of this happening with our junior residents. Maybe it's generational, because honestly, it's really been the last 2 or 3 years during our semi-annual reviews where a resident will come up to me and say, during my on-call shift, I've noticed that I just can't quite keep up with my co-resident. Where does the CCC committee feel as a whole I am in regard to speed? So I don't even really have to bring it up. They're much more proactive than I found they used to be, and maybe that's generational. It's a different topic for discussion, but that's kind of been my experience. And finally, the last thing I want to touch on with regard to monitoring progress is to set acceptable standards. And Scott talked about this a little bit as well. And I'll just emphasize that every resident is different. We all read at different paces. What we really want to identify are people at the far ends of this bell curve, right? You're going to get the 25th percentile, the 75th percentiles reads, but really, what about the 10th percentile, the 5th percentile on both sides? I mean, I've had residents who are extremely fast and not accurate, and it's really kind of narrowing that window and trying to bring everyone in. So we're all kind of working at the same pace, which we deem as acceptable and is going to prepare them well for the next level. So finally, the last thing that I wanted to kind of mention and bring up was the intervention side of things. And this was already kind of previously discussed, but I think acknowledging deficiencies, self-awareness, and having a desire to improve is important. And it's important to identify any issues. So we found sometimes some residents really struggle with search patterns. Maybe, they go through an abdomen pelvis, CT abdomen pelvis, and scroll through it 20 times. They're just not sure. They don't want to commit to something, but developing the search pattern and developing confidence in oneself has been an important part of what I found in helping these residents, even if it's like at 2 o'clock in the morning, just identifying it. Okay, how did you look through this study? I noticed you were on it for an hour. In our ED section, being proactive and kind of trying to figure out where the block might be. Maybe it's distractions. I've had residents like, if a call interrupts their search progress, they automatically start back from the beginning, especially long, complex studies that can be really hard. And you could kind of see how that would be contribute to a decreased speed. So distractions, search patterns, and honestly, in an age of pre-populated templates and numerous calls in the reading room, this can be a major issue and worthy of instruction. I would actually dedicate lectures to this with regard to understanding and promoting speed. If you dedicate lectures to it, it'll be important, and residents will see that as important. Same thing how we have now, not the same issue, but we have dedicated for personal finance, because we know personal finance is important to them and we want to make sure they understand it's important to them. The same with speed. So other things that we can do are assign mentors, monitor improvement. And honestly, one of the things I like to do is celebrate success. So, you can really make speed and improving speed fun, right? You throw around the word fun and you're like, you're making this hard work and going faster. Fun, how is that? Some of the things I've found is to really encourage residents. So let's say I'm on musculoskeletal radiology, we're on the bone board. I challenge them, 50 is a good average, but maybe you can push it to 60 and 70. They hit it, we're going to celebrate them, we're all in communication via chat across the department or even the section, so we can send out a woot woot or write their name on the whiteboard, so when their colleagues come in to say, oh, he set a record, and they're really proud of their accomplishment, right? So when they see that kind of accomplishment, I think it really is impactful to them, and they continue to try to push themselves to reach these goals. So finally, a few other interventions that I've found that are worthwhile is setting kind of short-term objectives. So it's easy to say, you know, let's do 50 MSK x-rays by the day. Well, maybe also kind of break up the block. So within the next hour, why don't you read, you know, 10 x-rays and we'll check out at 9 o'clock. Or even with our upper level residents, I want you to read 12 MRs, you know, by the time 11 o'clock rolls around, and that's when we're going to go over it. But that's kind of, you know, where I want you to be at this time. And every resident's different. And when I'm addressing this with them and giving them feedback, which is important, and you know, it's a requirement that we give them oral feedback, I think halfway through each rotation, but to try to do it as much as possible with regard to speed, you'll see more of a development. Finally, the last thing I want to say, and only halfway joking, is easy access to coffee in the department. Right. So, you know, if they're caffeinated and ready to go or have access to it, I found that they are much more eager to hit the list and running. And I'm only halfway kidding with that. So, you know, easy at whatever your vice is, Monster drinks. I've seen all sorts of energy drinks around the reading room sometimes, but I have seen that associated with some people to increase their speed. So that's kind of all that, you know, I wanted to impart for as far as short kind of my journey through this navigating, dealing with resident speed. I tried to make it more kind of open communication, and certainly, so if you have any questions, throw them in chat. If we have time at the end, I'll be happy to address anything in particular. But with that, I'm just going to kind of hand it over to David, who will give another great, interesting perspective.
There we go. Thanks, everyone. Again, I'm David Hodges. I've been in private practice radiology in Asheville, North Carolina for about 14 years now. I can assure you that speed is an ongoing topic in every private practice in the country. And so I'm happy to share some comments through that lens. You can see my outline here, what I'm going to cover, but basically I want to talk about why private practices think it's important, and then kind of walk through speed as it pertains to recruitment, hiring, getting a new hire up to speed, and then setting goals and monitoring for the long term. So why is speed important? There's a lot of words up here. Could it be money? Could it be work-life balance? Could it be quality, actually? When I was in training, I certainly thought that it was all about money, right? All private practice revenue streams generally relate to the number of reads that you do. So if you read more cases, you generate more revenue. What I've learned over the years is it's actually more nuanced than that, and has more to do with work-life balance within any private practice, where you really only have two currencies, time off and money. And if as a practice you decide to go after more of one than the other, you generally have to give up the other. What speed does is it allows you to actually shift the entire scale. So a practice that functions at a very efficient, high-producing level is able to get more time off and money compared to a practice that may have, in general, slower productivity or less productivity. And in reality, all private practices live on this spectrum somewhere, and it's important to know, especially for your trainees who are looking at jobs, to know where the practices they're looking at fall on that scale to know if it's a good fit. And finally, I do mention quality, and this has been commented on by Carol. You know, real quality, timely reports are needed by our referring clinicians to directly impact patient care decisions. It's critical. We all know that turnaround times are monitored by health systems, so they're certainly looking at it. And at the end of the day, timeliness is a component of how your patients, your referrers, and your health systems are going to perceive your care as being quality. I want to step forward now to the hiring philosophy, which is a bit like speed dating, in that, you know, we don't have a lot of time to evaluate candidates and have those conversations. And there's a lot of expectations on both parties. There are things that a practice is looking for, and there are things that a candidate is looking for. And as is well known, all frustration comes from unmet expectations. So it's critical that we get this right on the front end. When I think about a successful hiring process, basically, I mean that we're able to match our expectations with the performance of the person we hired. So what sort of information do we as private practices need from you, the program directors? And it's already been stated, often the first question out of the gate, are they fast? We as private practices, we'd love to have objective data if it's possible. You know, can you tell us what sort of an RVU load or a caseload per shift or per hour this resident is achieving? Or can you compare to other residents in that class or even recent years? Is the person we're talking about a top performer or average or a bottom 50% performer? We're quite used to the subjective data that we get in terms of comments and code words. And these are all comments that we've received over the last several years through the hiring process. So you may hear things like those on the left side, such as, you won't have a problem with their productivity, easily manages our busiest rotations, best resident I've seen in regards to quality and efficiency. And contrast that to the other quotes that we've heard on the right: average speed in their class, takes their time, very thorough reports. We all know what these mean on our end, but I will pause briefly just to say, you know, while Carol asked me to talk about speed, that's not all private practices are looking for. And some of these very positive comments on the left that we received were quickly followed by a but, you know, things like, but don't expect this person to build your practice, or don't expect this person to be a practice leader. So we certainly take those into great consideration as well, but the purpose of this talk is speed. Next, what information do we need from a candidate? I love it when I interview a candidate who can discuss their current level of productivity. What do they produce per shift, per hour? What's their current level of satisfaction with call shifts? If they're experiencing a high level of call throughout residency, a high level of stress throughout call, that level of stress is likely to carry on into private practice where things are not likely to be less busy. Can they compare themselves to other residents? One that I heard recently, speaking directly to a resident, was, I'm the fastest resident in my class. And that's good information to know. And finally, what information should I be providing to either you when we're talking about a reference check or to the candidate? I should be able to pretty accurately spell out what our productivity expectations are in general, globally, or by work slot, even better. What's my process in getting a new hire up to speed? And of course, what are our quality expectations? At the end of the day, for that successful hire to happen, just like any relationship in life, both parties need to be realistic. Neither should expect the other party to change. You want to make this a good fit from the beginning. Next, I want to talk about kind of some growth areas for speed. You know, and when we hire someone, particularly right out of training, we expect those first 6 months to be a steep learning curve. It's almost like the final step of training to get someone up to full speed. And there's some attributes and some growth areas that we've identified that we coach our candidates about in those first 6 months. And so we'll go through a few of those now. The first is stamina. Out of necessity, training, residency, and fellowship, there are multiple breaks built into the day, right? You have to have time for independent case review, time for readout, time for conferences, clinical conferences, educational conferences. Contrast that to private practice, where on day one, you know, it requires a sustained focus and performance for a shift that may range, at least in my practice, anywhere from 8 to 12 hours. There are no longer those built-in breaks. The next attribute, which has been commented on already, is confidence. You know, individuals need to learn to hone an efficient and comprehensive search pattern and always use it. Cutting out parts of your search pattern is not a strategy to get faster, because that leads to misses. These people need to develop the ability to make a decision and move on. If something is normal, feel confident in your decision, move on. And finally, learn what is appropriate to include and what can be left out of a concise and relevant report. We're asked to answer a question through imaging. We should be able to do that concisely, which is what at least my referring physicians prefer and ask for. Next up is time management. These individuals need to learn to manage interruptions. Answering a phone is part of the job. Refusing to answer questions or talk to referring physicians who may come into the reading room is not a strategy to improve your speed. You must learn to minimize any non-work related distractions, turn your phone off if that's what's required, and learn what is appropriate for that practice in terms of taking time for breaks. And finally, this has been commented on as well, but you really have to to leverage your information technology to work smarter, not harder. You need to know your PACS, VR, EMR, AI system platforms inside and out. Optimize your hanging protocols, optimize your monitor setup and layout. Mouse and keyboard shortcuts are critical at a private practice pace. I put a picture on here. One of the best changes I made several years ago, along with multiple of my colleagues, was to purchase a gaming mouse, map my common keyboard shortcuts to the keys on the mouse. And now I have things like the arrow, the ruler, flipping images, all at my fingertips, which dramatically improves workflow. And of course, VR templates and macros. If anybody's saying the same phrase over and over again, it should be converted to a macro so that you can use it in a much more efficient manner. Now that we've talked about kind of that new hire and coaching on those attributes, getting up to speed, we also have to talk about goal setting, right? You can't just tell someone to be fast or be faster without knowing where they're starting and where you want to get them to. So you may be familiar with these SMART goals, but basically we have to have things that are measurable. When you enter private practice, you need to realize that people are watching, right? It could be me being watched by this little white balloon as it flew over my house a couple of weeks ago. It could be Big Brother, but in private practice, there are people looking at productivity. And everyone needs to know that. And that's not to scare people. It's just an awareness that it's happening whether you know it or not. So how do we use that data at my practice at ARA Health? Well, first, we have to establish benchmarks. Those benchmarks are set for every work slot that we have. They're based on historical productivity data and are designed to be a benchmark that can easily be hit by everyone. We've also set a practice-wide minimum expectation of 6 RVUs per hour, regardless of work slot. And then to put those benchmarks and minimums to work, we have to measure individual production. Most people want to succeed, and our goal here is self-correction in low-producing physicians. And that is actually what we've seen with these tools, which I'm going to cover next. So first of all, we have a daily productivity available to all of our radiologists through a smartphone app. You can pull this up during your workday. In fact, this is mine from earlier today. This is synced to our scheduling app, so it knows what slot I'm in to know where the benchmark is set, and the benchmark ticks through the day accordingly by the hour. And the goal is, or expectation is, I should remain in the green on this meter at all points of the day. And when my shift hours are done, I should be in the green before I go home. If not, I may need to stay late to get there. Next, we report out quarterly aggregate data to show people how they're performing. This is our report card, which fits nicely all on one page, although that's a little bit small to see here. So I'll walk you through kind of each line just so you know what we're looking at and what we're reporting. That top line is here. You see there's the physician on the top row, the benchmark underneath. So we're reporting out aggregate work RVUs. We break that down by RVUs per day, RVUs per hour, RVUs per shift. You can see the benchmark numbers below. So this person is exceeding all of the benchmarks. And I'll tell you that last year, our practice-wide average for all shifts was right at 8 RVUs an hour. That's higher than the benchmark. Again, we set these benchmarks because we want everybody to succeed. We don't want to set things at the average where you're going to have a 50% failure rate by definition. That middle row I broke down shows individual production by slot. So you can see this is an ER slot, this is an evening slot, this is an MSK slot. And you see where the physician ranks in terms of production compared to the benchmark, which in this case is the average production for that slot, and compared to the calculated benchmark, which again is lower. And finally, at the bottom, we show some other just interesting pieces. What sort of slots was this person working? And what was the modality mix? Where's the vast majority of their RVUs coming from? So then we use that data, in terms of the baseline minimum. If we have any person falling below the expectation, that minimum expectation, they get referred to our MD personnel committee for support. Possible interventions, including CME and problem areas. We may remove that individual from specific work slots if it's mutually agreeable to the individual and the group. They may have to have longer work slot hours compared to their colleagues. And at the end, you could be talking about reduced pay for that individual. From a new hires perspective, we do review this data prior to a partnership vote. If there is poor performance, which again is reviewed with other pertinent information, there are several outcomes. This hire may elect to leave to find another practice with a better fit. You may have a failed partnership vote, or you could have a successful partnership vote, but a poor reputation and relationship with your colleagues moving forward. Just a couple final suggestions to close with. First of all, tips for you program directors. I would encourage you to incorporate speed into training. That's the purpose about this session today. And coach some of those attributes such as stamina, confidence, time management, and IT efficiencies. Those are skills that can be learned early on, I believe. Develop a process for evaluating speed and be able to share that data with your residents and fellows, and ultimately us if possible when we're in the recruitment process. And assist your residents in finding a realistic fit for their long-term job satisfaction. It's going to be important for them to know where the practice is on that speed scale to know if it's a good fit. And finally, tips for residents and fellows. If this information does get back to them, I encourage them to work on speed, especially starting in their 4th year. Practice working at faster and faster speeds while you still have that backup and security of a readout from faculty. That's really going to teach you where your blind spots are. Moonlight as if available, which is great experience. Become literate in your current productivity and be able to talk about this with prospective practices. And then finally, of course, be realistic in matching your skills with the expectations of prospective practices. So with that, I'll conclude. I've left my email on here. Happy to answer any questions that may arise later, and also happy to answer any now if there are any.
Yeah, hey, David, thanks a lot. We've been trying to answer along the chat. And again, I think part of the point of this webinar was just to kind of bring up the topic amongst us. I'll own it that I've been a program director for 11 years. And it's been really pretty recently that I've really started to have any of these conversations with my residents. And other program directors on here, I'm sure, are way better than me and have been having them for years, but I haven't, and I'm probably not alone. I think, again, because volumes are rising, and I'm still kind of trying to think about ways to help residents get better. I do want to say, let me just see if I can you all see this slide? Scott, Eric, y'all see this? I will say that I'm hoping that futuristically our conversations start moving for ways, how do we actually, if we identify a resident that is on the end of the bell curve, I think Eric put in the chat room, there's a bell curve, and I'm not the fastest person in my group by any means, and I had to work on strategies to get myself faster. But when we identify a resident that maybe is on the far end of the bell curve, how do we help them? I have to credit Kyler Harden, again, one of our residents who we had a lot of talk about this, and this is some residents' perspective on some things they think they can do for what it's worth. Again, this is coming from residents, not from me, but they say don't cherry pick during the daytime rotations. Encourage your residents to really practice working through complex cases, because that's going to increase your efficiency for those cases and the easier cases. The residents themselves think that, I'm going to try to do this with our new first years this year. I haven't done this, but really try to help them optimize their software. David just talked about this, really optimize some of those PowerScribe smart phrases, keyboard shortcuts, mouse. I notice our residents are getting those gaming mouses, and, this is kind of a thing. I think maybe we should be providing this. The residents say that you need to just get confident on being fast on normals. Go back and look at the normal 3 times. You got to get used to looking at it once. I think everybody's talked about search patterns. When I meet with residents and talk to them about speed, a lot of them, when I get down to talking to them about what they're doing, their search patterns are really a little messy. And so that's kind of a very actionable thing. And talking about, again, the residents talk about ancillary search patterns depending on clinical situation so that you tailor your time efficiently based on the clinical question. I probably don't do enough time talking to residents about this ancillary search pattern, focusing on that. And again, this comes from residents. They say push the pace on the daytime clinical services. This is a time to try it out, see how fast you can go before your accuracy suffers in a safe environment. And, again, encouraging residents that seeing more cases equals more experience. And that does increase speed. And I think Priscilla Slant has put it out in the chat. I think a lot of people have said this. I mean, there's always going to be a bell curve of speed. So the thing to do is, I think, kind of try to help everyone reach their potential individually, because I think being successful, it is what it is. I think we have to pay attention to it. And we hope that this roundtable is going to open, discussions on, again, I've just started this past year showing that keeping track of the RVU numbers for our R4 residents and going over them in their semi-annual eval, so that as they're looking for jobs, they can say to themselves, well, gosh, I certainly don't want to take a job that's like way over this because I'm going to have trouble with it. So I think there's some things maybe as program directors we can do to help prepare them for what type of job maybe they should be looking for. And again, I'll stop there. And some people put in some really helpful things. Someone asked me in the Q&A, we use Montage in our program, and that tracks the residents' RVUs, and they will go and look at those themselves as well. So I don't know if we used a lot of the time here, but again, I think we're hoping that this will be a conversation for future meetings and, helping each other with what tools everybody's using. So, and if somebody has a question, they can unmute you too. If it's not, we may be right at the time. Yeah, I think people put in the chat box, of course, Quinsight. So there's, again, I think there's some tools, some software tools that we can use. And, I think Dr. Fleming put in there, there's an article about, reading more studies and not passing the exams. I mean, it's, as program directors, of course, there's a balance in all of it, trying to teach our residents, obviously accuracy and knowledge, and going fast. And I think all of us have the experience on the flip side where we have residents who are going too fast and they're missing stuff. And that's a huge problem. That to me is a worse problem. And I think we all get on that very quickly. So I think, that's where we are. And thanks to everyone for attending. Thanks so much, Scott, Eric, and David. David, especially thanks to you for sharing. I think a lot of times it's good for us to hear from our private practice colleagues on what they're seeing on their end. So appreciate it.
Thank you.
Anytime. Thanks, everybody. Great job.
Thanks, everyone.
Yeah, thank you.
Thanks for attending.